Hi. I think we've kicked off, I'm told, which is cool. And I hope you're well. I'm going to talk about immune therapy in early bladder cancer. I'm going to talk a bit about bladder cancer generally, and then I'm going to focus on early disease because I think that's interesting. So I'm going to talk for 30 minutes. I get bored of my own voice after about 20. So please ask questions. Do join in. Do ask me questions, and thank you for attending. I have a number of conflicts of interest, as you can see. I'm happy to talk about any of them at any point. I think I'm fairly equally unbalanced, I hope. I'm going to use different data slides, and I haven't put some of the references on the slides, but this is essentially where the data comes from. And this is my first slide. So I think a really good place to start is around immune therapy and immune checkpoint inhibitors. And I'm going to spend a minute or so just talking a bit about the 5 drugs that are approved in the US. And remember, it's only atezolizumab, nivolumab, and pembrolizumab that are approved in Europe. If you're from the US and you're listening to this, welcome, but it is the 4th of July. So you should probably be out there having a barbecue or something. So I think it's going to be mainly a European audience. But if you are from the US, you're very welcome. The US has durvalumab and avelumab, which are both PD-L1 inhibitors. We have atezolizumab and pembrolizumab, and that's both in the cisplatin ineligible space frontline, but also and that's in the biomarker positive platinum ineligible space. But we also have all 3 drugs in platinum refractory space in unselected patients. As you know, the EMA and FDA licenses have changed quite recently, and I'm going to talk a bit about that in a minute. I'm actually not doing biomarkers today. Now, if you've got questions on biomarkers, please ask them. The reason I'm not going to spend too much time on biomarkers is it takes me about half an hour, and it's not complicated, but I'm going to try and summarize it as I go along. But what I would say is the PD-L1 biomarker is just very confusing at the moment because each drug uses a different biomarker. And you can use immune cells or tumor cell staining. You can set different cut points, and there are different antibodies. So there are an infinite number of permutations and combinations for biomarker analysis. Inevitably, some biomarkers seem to work in some trials and some seem not to work in other trials. I would make one important point is that there's a lot of uncertainty around this, and it's not unreasonable to say we don't know how the biomarkers work in early disease. This next slide is actually data on, it's a color-coded slide. I made it myself. I call it a wedding cake, so actually it's not fair. Charlotte, who works with me, made it. I'm not capable of doing something as complicated as this. And she did a great job. It's a wedding cake kind of slide, so different pieces to the cake, obviously, and each drug is color-coded. And the darker colors are the response rate and the biomarker positives. And the blue is a good example when we go from the phase 1 to the phase 2 to the phase 3, and you can see the response rate decreasing, the biomarker positives, and the overall response rate decreasing as well. The arrow points to the randomized phase 3 study, the positive randomized phase 3 trial, which we know a lot about, and I'm going to talk a little bit about that in a second. But essentially, this shows how much uncertainty there is in the area. But the bottom line is response rates, probably about 20% in unselected patients and about 30% in biomarker positive patients. And that seems reasonable. This is one of the randomized phase 3 studies. This is actually the atezolizumab versus chemotherapy randomized phase 3 study. I picked this trial because it's more complicated than the pembrolizumab trial. The pembrolizumab study was relatively straightforward in as much as it was an all-comers unselected study and had a hazard ratio of 0.73 versus chemotherapy in cisplatin ineligible patients. And essentially what that means is that all patients do better, overall patients do better with immune therapy than chemotherapy, and there's about a 27% reduction in the risk of death. This is the biomarker-driven atezolizumab study that I was involved with. And in this trial, we actually selected the biomarker-positive population. As I said before, the biomarker positive population is a bit complicated. And this trial actually turned out to be negative in that while the blue line outperforms the red line, particularly in this tail at the end here, overall, the results weren't statistically significant in terms of their difference. And the reason for that was the biomarker selected the winners. The reason I showed this slide is we're talking about early disease today, and I'm nervous about doing trials in the future where we only select biomarker positive patients. The first line setting is probably more relevant than the second line setting because it's earlier in terms of closer to the muscle invasive setting, which is going to be most of what I talk about. This slide may be really important, well, it's really important because we know atezolizumab and pembrolizumab are active in this setting, but we don't really know how active they are because we don't have randomized data. And you can see compared to chemotherapy, the response rates are lower. And I want you to bear that in mind for a second because I'm going to show you some neoadjuvant data in a minute which turns this upside down. So in the metastatic setting, even the frontline metastatic setting, response rates are lower, progression-free survival is shorter, and overall survival we don't know. What we do know is that both the EMA and FDA both approved both atezolizumab and pembrolizumab on those two trials. Some people feel that might have been a touch hasty. At the time it seemed like maybe a good idea, but as we know, that label has now changed. So if you're cisplatin ineligible, and this is perhaps the most important educational point for today, if you're cisplatin ineligible, you really have to be PD-L1 biomarker positive to receive therapy. So just to repeat that, cisplatin ineligible, if you want to give atezolizumab or pembrolizumab, you need to be biomarker positive. The EMA and FDA have both changed their labels based on that, but they're based it on randomized data that we've not seen. That's really confusing. So we don't know why they've done it, but we know they've looked at this data, and there must be harm going on in this biomarker negative population. So that's the clinical point, and I'm sure all of you at home are already really keyed in with that question. But if there are any questions around that, I'm really happy to answer it because it's really important. I'm nervous we're doing harm to some patients, and that's particularly those biomarker negative patients. The more observant in the audience I won't make any more jokes. The more observant in the audience may say, you know, Tom, you just told me the biomarker was useless in the second line setting, and now you're saying you have to use it front line. What's changing? And I don't know the answer to that question. What I can tell you is there's some nice work from Ellie Van Allen's group which shows changing, dynamic changes to biomarkers, to the PD-L1 biomarker associated with chemotherapy. And it might be actually that these biomarkers, the PD-L1 protein biomarker, is quite unstable. This is quite an important message as I see it, because it means not only are we uncertain about the biomarker, but also it looks like the biomarker can change within individual cancers. So just because it works here doesn't mean it's going to work there. Really important for the perioperative space, because the trials we've designed are complicated, and I'm keen on feedback from the group too, if possible, from those. And these are those frontline trials. These are the trials that the EMA and FDA must have looked at to change the label. And the results of these trials, you know, they're expected pretty soon, some of them, actually. I mean, some of them we might have even expected by now. Two big groups of trials, the chemotherapy combination trials and the immune combination trials. So I draw your attention to atezolizumab versus atezolizumab plus chemotherapy versus chemotherapy. The same applies for pembrolizumab. And then the purple trial, durvalumab versus durvalumab and tremelimumab. I've not talked about tremelimumab so far. Tremelimumab is a CTLA-4 inhibitor. You might know ipilimumab, and it's very similar to ipilimumab. And the reason that's important is it's not asking the chemotherapy combination question. It's actually asking immune combination questions. And this is really important for early disease. And I want you to keep that thought in the back of your mind for immune combinations in early disease, because I'm going to talk about that in a minute. In metastatic disease, just like the biomarker didn't seem to work very well second line, immune combination therapy doesn't appear to work very well second line. But I always say expect the unexpected in bladder cancer. And just because we're not getting fantastic results second line, doesn't mean immune combination therapy won't work in the perioperative setting. I'm actually quite excited about perioperative trials. We're going to get some results this year, and they're going to be really important. They're going to build on some of the work we've done already. I show this slide for a specific reason. I show this slide because we are now doing neoadjuvant chemotherapy combination trials. So chemotherapy plus immune therapy in the neoadjuvant setting, and we're going to get data in the not too distant future in the frontline metastatic setting. If that data is anything like lung cancer, we're going to have really positive studies. So this is a hazard ratio for survival of 0.5. These are exceptionally good results. And even if we're half as good as this with hazard ratios of 0.75 in bladder cancer, and I'm really expecting that, if we are, that will change frontline, but also it will point to positive neoadjuvant trials in the future, which I think is really important for our patients. So just to summarize what I've said so far, I'm not going to spend too long talking about second line immune therapy. I hope we won't be talking about it too much in the future because it's moving to the frontline setting. There are immune combination studies and there are chemotherapy combination trials. There are also monotherapy studies. We know the monotherapy studies have had to change because the biomarker positivity, and the biomarker positivity is important. The earlier space with chemotherapy combinations and immune combinations will read out in the not too distant future. So we're now going to talk about this earlier disease. We're going to talk about muscle invasive disease here, but we're also going to talk about earlier disease, T1, TA, and CIS, and that's a really exciting area. This slide just summarizes that actually perhaps we haven't met our initial expectations. And I'm talking about this a lot at the moment. When we started this journey 3 years or 4 or 5 years ago now, I thought that combinations, I thought that biomarkers were going to be the most important issue. As I currently think, it may turn out that actually the right setting, the adjuvant, the neoadjuvant setting, the non-muscle invasive setting may be the place not to do with combinations. Clearly, I'm very hopeful that the frontline metastatic trials are going to be positive, but I also feel this perioperative space is going to be really important. This trial is this study here is a meta-analysis of neoadjuvant trials. And what I would say about this is that chemotherapy is associated with a benefit, but that benefit is relatively modest. It's somewhere between 5 and 13%, 5% in this meta-analysis. So you get 4 cycles of chemotherapy followed by cystectomy, and you get an increase in survival by 5%. Me and many people around me feel that we can beat this 5% with immune therapy. But there are 2 key questions about how we improve this, and that's what I'm going to try and talk a bit about today. One of the questions that I'm most commonly asked is what chemotherapy do we need to give in the neoadjuvant setting? In the randomized trials, we gave CMV and the CMV was positive. We give GemCis regularly and some people give MVAC. Different regimes require different thought, I imagine, but actually there's no real evidence that one regime is a whole lot better than another. And that's essentially what this curve shows here. So we can see that first is control, you can see chemotherapy winning, but when you compare one agent with another, it probably doesn't make very much difference. In the prospective randomized trials, for what it's worth, we're using GemCis. I'm very aware in North America, many people use MVAC, but as I said, I think they're all on the 4th of July holiday, so that doesn't matter so much. In our institution, we use 3 or 4 cycles of GemCis. 4 cycles is perceived to be a standard of care, but 3 is probably acceptable as well. This is the only adjuvant study I'm going to show. We don't give adjuvant therapy. The meta-analyses have not been that positive. This is actually Walt Sadler's study where he did a selected population P53 mutant adjuvant trial, and you can see no benefit here. There's Cora Sternberg's excellent EORTC study that showed a PFS advantage and a non-significant survival advantage. I actually think the jury's out in the adjuvant space. But overall, I think the global community feels that neoadjuvant chemotherapy and not adjuvant chemotherapy is the standard of care. I am not a believer in giving neoadjuvant therapy and adjuvant therapy in the same patient. I've seen people do it, people phone me up about it. I think you give neoadjuvant chemotherapy, and those patients that aren't doing well should get immune therapy when they relapse. There seems no point in giving adjuvant chemotherapy after neoadjuvant chemotherapy. If it's not worked in the neoadjuvant setting, I don't see why it's suddenly going to work in the adjuvant setting. And these benefits at most are about 5% anyway. So the perioperative space, T2 to T4A, N0 disease, we're giving 3 or 4 cycles of neoadjuvant GemCis, but we know 50% of patients are not eligible for GemCis. Those patients are having cystectomy alone. PURE-1 is a neoadjuvant study of pembrolizumab in individuals who were eligible, fit for both cystectomy and neoadjuvant chemotherapy. This is 3 cycles of drug, and these are the results of the trial. This study shows a response rate of 40%, 40. This is published in the JCO. And 40% response rate for only 9 weeks of pembrolizumab in unselected patients is really very impressive. Remember, chemotherapy response rates are probably somewhere between 25 and 35%. You can sometimes get as high as 50 in some studies. But this really, in my mind, changes the way we look at things. The reason it changes the way we look at things, it may be possible to give either single agent or combination of immune therapy up front, cystectomy, and then, based on biomarkers, decide on how we're going to treat these patients. Abacus is another trial looking at only 2 cycles of atezolizumab. Atezolizumab being a PD-1 inhibitor, or PD-L1 inhibitor, rather than pembro as a PD-1 inhibitor. 2 cycles of atezolizumab associated with a 30% response rate, going up to 40% in the PD-L1 positives. You can show immune-related reactions ongoing. This is really exciting. You can also show dynamic changes to the biomarkers. Those dynamic changes associated with upregulation of PD-L1, upregulation of CD8. So what we're seeing, in summary, in the neoadjuvant space, is we're seeing higher than expected response rates based off short periods of therapy in a setting where chemotherapy is of modest benefit. Chemotherapy in the metastatic setting appears more active than this, and immune therapy actually appears less active. Therefore, in my opinion, it's conceivable we're going to be giving immune therapy to unselected patients initially, either with chemotherapy or alone, performing a cystectomy, and then going on down a directed type approach. Many people ask me, is there any data out there currently on chemotherapy plus immune therapy in the neoadjuvant space? And the answer there is. There's some pembro data with chemotherapy. You can see here the response rates are high, but not spectacularly high. There's a lot of work to be done in this setting because these numbers are small. It's still not absolutely clear about whether the chemotherapy combination approach is going to be positive. My feeling it is. And there are a number of trials that are ongoing. And I'm going to talk a lot about those trials in a second, but I'm just going to talk about the platinum eligible trials to start with. So in the platinum eligible trials, there is neoadjuvant chemotherapy plus durvalumab and neoadjuvant chemotherapy plus pembrolizumab. In the platinum ineligible trials, there's neoadjuvant pembrolizumab alone, and there's neoadjuvant nectar plus nivolumab in a 3-arm trial. And then in the adjuvant setting, we have these 3 studies. These trials together probably cover 5,000 patients. In view of what I've said so far, common sense dictates that most of these will probably be positive. This may actually be the best place to test immune checkpoint inhibitors in this disease. This slide here is complicated on purpose. What it's supposed to summarize is actually what's going on in the space beyond just the randomized phase 3 studies. There are 2 really exciting drugs. There's erdafitinib, which is an FGF inhibitor, and there's enfortumab vedotin, which is an antibody drug conjugate targeting nectin. I think both these drugs will be approved. Erdafitinib already is approved in the United States. I think enfortumab vedotin will probably get approved as well, off some of the data that's available in the public domain. My feeling is that that will change the landscape, because then we're going to be giving targeted therapy alone, targeted therapy, antibody drug conjugates, targeted therapy, immune therapy, antibody drug conjugates, and chemotherapy. We're going to be giving these in the neoadjuvant space. We're going to be looking at cystectomies and maybe even bladder sparing approaches. And then we're going to be giving periods of adjuvant therapy as well. There are slides like this in breast cancer, and they're as complicated as this, but actually it's a standard of care. Bladder cancer is likely to go down a similar route. There's going to be a huge change in this space in the near future. Niagara is one of the ongoing randomized phase 3 trials. Neoadjuvant GEM-CIS versus neoadjuvant GEM-CIS plus durvalumab. Very simple design, randomized phase 3, 1,000 patients. It's one of the studies. Take part. It's open at our site. It opened yesterday at St. Bartholomew's site. But I think it's a really important study. There are a number of adjuvant studies, some of which have completed their enrollment. Those adjuvant studies we expect to read out relatively soon. So far, I've talked about the second-line metastatic setting. I've said I don't think we're going to be using the drugs there in the future. I've talked about the dynamic changes in the frontline space. And now I've talked about this really exciting perioperative area, the neoadjuvant and the adjuvant space. I've shown you data showing higher than expected results or response rate results in this group of patients, which is extremely hopeful for our patients in the future. I'm now going to talk about maybe the most controversial area. Keynote 57 is a study, and I know Arjun and Ronald, and I've spoken to them about this in detail, as well as the team, the pembrolizumab team. This is really exciting because the prevalence of urothelial cancer is extremely high. And this is a group of patients who are unresponsive to BCG, who normally would be going on and getting cystectomy. The question is, can we give immune therapy to delay that cystectomy? I'm not going to spend too long on the definitions of BCG unresponsiveness. There are 2 key issues around BCG as it currently stands. Number 1 is we don't really know how it works. There seems to be an important component of dendritic cell activity. Number 2 is there seems to be a global lack of BCG. And thirdly, I said 2, there are 3 things. Thirdly, a number of patients fail BCG, and you can either fail immediately, which is being BCG unresponsive, or you can relapse after having a period of BCG and maintenance therapy. As it currently stands, we have good, intermediate, and high-risk disease. Patients get an induction period and then a maintenance period. There's a debate about how long the maintenance period should be in high-risk disease. This study was nicely designed, and it had 130 patients in cohort A, which I'm going to talk about today, and that is CIS, with or without papillary disease, and also then cohort B, which I'm not going to talk about today. And basically, you're getting pembrolizumab, and then looking in the bladder on a regular basis for relapse. The statistical methods are interesting because, and I don't normally put statistical method slides up, because we're assessing CR rates. When I go to CR to talk to oncologists about CR, what they're thinking about is a radiological complete response in target lesions with no cancer remaining. Clearly, this setting is different from that because this is a pathological CR, and this is in many patients who have had a TURBT. So it's not clear that whether or not it's actually relapse or time to relapse as opposed to CR. I'm really happy to answer questions around this at the end because I think it is confusing. We're having the same debate in kidney cancer at the moment, and this CR issue is important. These are the characteristics of the patients. And you can see here in one of the red boxes, tumour patterns at study entry is important. So CIS alone is 63%, and then CIS with some other disease fulfilling the other 35% of patients. And this is relatively important because at 3 months, you can see this CR rate of 40% is higher than you would imagine. This is a relatively short period of therapy, and I understand many people say, well, there are a high number of patients who are just waiting for relapse in this situation, and I understand that debate. But what I would suggest to you is this shows that there is some activity in this BCG-unresponsive population. And this is really exciting for 2 reasons. Number one is we can combine with other drugs like BCG. And number 2 is we can move these drugs earlier into the disease where the pattern of disease is much more common. Because I understand that BCG refractory, the moment you're getting cystectomy, the number of patients we're seeing is relatively modest. This curve shows duration of response, and this is important because what it is telling us is that if you do respond and you do achieve that CR at 3 months, it doesn't last forever in all patients. And actually you can see while there was a tail to this curve, and if we could, dare I use the word cure, but if we could put 50% into long-term durable remission, that would be a huge step in the right direction. I'm not suggesting that pembrolizumab is removing this disease completely. So what I would say by this disease, this data so far is it's promising and provocative. It's an area of huge unmet need, and so therefore it's attractive, but clearly we need more work in the future. I've not talked about adverse events at all. I've done that on purpose because in the metastatic setting, certainly, adverse events are not that relevant. They're relevant, but patients need to have systemic therapy to try and go into long-term durable remissions, particularly with immune therapy. And all patients, well, almost all patients, are prepared to take that risk. As we come into the perioperative space, the risk becomes lower from the cancer, speaking frankly. Some patients are cured with cystectomy alone. In this setting, the risks actually and the benefits are greater, in that clearly we can't be having too many grade 5 treatment-related deaths because the proportion of patients in harm's way in this setting are relatively modest, and some people might say, well, let's do cystectomy anyway. This is really important for the future, is assessing risk versus benefit, and adverse events has a huge role to play in that. I've actually gone for half an hour, which I thought was longer than I was expecting. I'm gonna just summarize what I've said so far in the metastatic, in the non-muscle invasive and the muscle invasive space. So in the muscle invasive space, we've shown significant activity. We're doing randomized trials, and those randomized trials involve chemotherapy and immune therapy alone, and I suspect they will involve immune therapy, targeted therapy, and immune therapy antibody drug conjugates in the not too distant future. That's based on the excellent activity of the latter drugs. This movement into the BCG refractory disease, sorry, there's a mistake, movement into the BCG refractory disease, but also the non-BCG refractory disease, this earlier setting as time goes by is really important. I've showed you data in BCG refractory disease, but we're also doing studies in an earlier setting, Potomac being an example of that, of individuals with high risk BCG naive disease, where we're randomizing immune therapy plus BCG versus BCG alone in the hope of curing more patients. I talked a little bit about the risk and benefit associated with the two treatments. Those two treatments being BCG, but also when you add in the immune therapy, the toxicity is likely to increase. We're going to need to show significant benefits for that reason. And the last point I'd like to make is as we go into this space with immune checkpoint inhibitors, there are actually a large number of randomized trials. So at our centre, we probably have 4 studies open currently in this environment. This is important because I think for the first time we have 1,000 patient trials, which are going to answer some of the really important questions that we've been struggling with up to now. Some of those are relatively simple, that we should have probably answered by now. And so we're going to have a whole lot of very robust data in this space in the very near future. That was all I wanted to say. I wanted to give you the opportunity to ask a couple of questions before we stop. So let's fire away with those questions. I'm going to answer the 2 questions I was asked last week. The first question I was asked last week, which I think was really important, is what's the role of radiotherapy in muscle invasive bladder cancer in the area of immune checkpoint inhibitors? And I think the point of that question was, at the moment in the UK and around the world, some centres are giving radiation therapy instead of cystectomy. And if the adjuvant studies were positive, should we be giving adjuvant immune therapy to those patients as well? That's almost an impossible question, because we haven't got the data, we won't have the data. There are some small trials going on. I think those trials are incredibly important. There's a really nice Canadian study, which is looking at some of these issues. The question that I think needs to be answered is twofold. Number one is people talk about a synergistic effect between radiation therapy and immune therapy, because the radiation releases neoantigens, which may in turn result in increased efficacy. We currently don't have any evidence to support that. My personal opinion, and this is a personal opinion, is immune therapy currently has no role. If the adjuvant trials were positive, and we'll find out fairly soon, I would be and they need to be quite, they need to be properly positive, and hazard ratios of 0.6s or 0.7s for survival. Under those circumstances, I think there's a compelling argument to give periods of adjuvant therapy after radiation therapy as well. You might actually turn that round and say it would be even more important in the radiation population to give the adjuvant therapy, because that's at higher risk. The difficulty with advising that is we haven't got data to support it. The next question that I was asked last week was around biomarkers in the neoadjuvant setting and what's the role of tumour mutational burden versus PD-L1. Tumour mutational burden looks at the complexity of the cancer. PD-L1 just looks at the expression of the biomarker. Tumour mutational burden is a surrogate for the need for immune evasion. If you have a very complex tumour, it's going to require a lot of immune checkpoints, a lot of immune evasion to hide, because clearly a very complex tumour should be easily recognised by the immune system. High tumour mutational burden is associated with higher response rates in metastatic disease. Data in the perioperative setting is more complex than that. In the neoadjuvant studies in melanoma, tumour mutational burden hasn't worked. In the PURE-1 trial, the pembrolizumab neoadjuvant study, TMB did seem to correlate with some other markers. In the Abacus trial, it didn't work. Tumour mutational burden was not predictive. And so what we currently have is a situation where we have biomarker uncertainty. And under those circumstances, we should not be using tumour mutational burden to select patients for either metastatic disease, but more particularly in the perioperative setting. I've got a question. One from Richard Sylvester. Hello, Richard. How are you? Thank you for asking the question. In Keynote 57, is there information about the number of CRs who progressed to muscle-invasive bladder cancer or had cystectomy? Yes, Richard. So that data is coming out, and at the moment, the data is patients are not progressing to cystectomy, and so that is actually the good news around there. So although we have got relapses, they're not currently going on and getting muscle-invasive disease. But the data is still premature, because, in my opinion, because remember, the really important thing here is this is my opinion, and I realise not everyone shares this, If we're really going to make a big difference here, we can't just delay a cystectomy by 6 months. We need the 2 and the 3 and the 5-year data. Because I don't think, if you say to patients, you've got to have this drug for a month, for a year, or 2 years, they're not going to want to just delay their cystectomy by 6 months. I think you're going to have to delay cystectomy in big groups of patients, 40% of patients, and I think that's going to need to be 2 or 3 years down the line. Because if it's only 6 months, many patients would say, listen, let's get on with it now. So Richard, that's my opinion. We're currently, and the follow-up is obviously longer than 6 months, so it currently stands. As it looks at the moment, we can delay that. So that's the first question. I've got another great question here. What do you think about the major complications rate related to neoadjuvant trials? And that's from Maria Mia. Thank you very much for asking that question. I actually know a little bit about that because we were involved with Abacus, and I've spoken to Andrea about Pure One. There are 2 really important things around the neoadjuvant studies, and I've just got off the phone to one of the positive randomized trials, and I'm pleased there's so many of you who are taking part in those studies. Listen, the really important thing here is the patients get the cystectomy, because that's the curative procedure. What we did in both Pure One and in Abacus is we said, whatever happens, this patient is getting a cystectomy in the near future. One of my nervousness is, that's not really an English word now. What makes me nervous, I think that's a bit better. What makes me nervous is you give 2 cycles of atezolizumab and then they get a grade 3 transaminitis and you delay the surgery by a month and a half or 2 months. We need to avoid that. And so the way to, and yes, the neoadjuvant treatments, just like the metastatic treatments, are associated with classic side effects, colitis, pneumonitis, transaminitis, and they will increase with combination type therapy. We had one patient who developed insulin requiring diabetes from an autoimmune phenomena. So I think when you pull that together, you said you're giving drugs which are 90% of patients, 80%, 90% of patients are getting away without any problems. But those 10% who are getting significant problems, you need to intervene quickly with steroids. And when you do intervene, my advice to you is don't then go back in with more and more immune therapy if the surgery date is coming up soon, because what you'll find is you don't have delaying the surgery. So what we did in Abacus is we gave 1 cycle to actually 20% of the patients only got 1 cycle, because if you've got grade 3 toxicity, don't give the 2nd cycle. Remember, the immune drugs have a long half-life of 6 weeks, so they're probably kicking around. Make sure that cystectomy is done well and done properly, as always. In terms of the surgical complications, Calvin-Dindo complications associated with surgery, we looked at that and we didn't show any particular trends. So one of the concerns was, would you show increased autoimmune type disease, wound healing and other bits and pieces? And we didn't show any of those phenomena. And actually, when patients came out the other side of immune therapy, we gave some chemotherapy. We didn't give adjuvant immune therapy. In the ongoing trials, there'll be adjuvant immune therapy as well. And in that environment, it looks like the surgical complications are low. So the good news is, the majority of patients getting immune therapy, no problems. Those that are getting problems, intervene early with steroids and don't keep going with more and more immune therapy. Get the surgery out of the way, and if necessary, give the adjuvant immune therapy in the upcoming trials. That's my last question, and I've been going for a bit longer than I hoped because I didn't want to take up too much of your precious time. Lovely. Well, look, I'd just like to say thanks so much for taking up your valuable time on a beautiful Thursday evening here in London, and I'm sure where you are as well. I hope the heat wave in Europe is coming to an end. It never really managed to get off the ground in the UK, but that's not to be surprised. And see you all very soon, I hope. This is a really exciting area, and please take part in the trials. And do email me if you'd like to take part, because I might be able to help getting some sites open. We're always looking for new sites. Thank you very much for your attention.